Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 317 of our pharmacotherapy series, which majors in shock. The first question reads, NGT is a 64-year-old woman with a history of peptic ulcer disease, who arrives to the emergency department complaining of diffuse abdominal pain and bright red blood in her stool over the past 2 days. She is confused and oriented only to person. Her skin is pale and cool, with heart rate of 120 beats per minute, SBP 80 mm of mercury, and a respiratory rate of 28 breaths per minute. Describe the physiologic changes in NGT in response to her gastrointestinal bleeding. What are the goals of resuscitation in patients with hemorrhagic shock? NGT has lost a significant amount of intravascular fluid directly from her GI tract. She is hypotensive with a compensatory increase in both heart rate and respiratory rate. Her pale, cool skin indicates shunting of blood from the periphery to maintain perfusion of vital organs. Based on her clinical presentation, NGT is in decompensated shock. The major hemodynamic abnormality in hypovolemic shock is decreased venous return that is preload to the heart, resulting in a decrease in cardiac output. Oxygen delivery to the tissues is reduced from this and the loss of oxygen-carrying hemoglobin. The physiologic response of the body to a sudden decrease in volume, that is preload, is to activate the hypothalamic pituitary adrenal axis and autonomic nervous system to release catecholamines, that is epinephrine, and norepinephrine. The subsequent increase in heart rate and contractility help maintain cardiac output. The peripheral vasoconstriction caused by the sympathomimetic response helps maintain arterial pressure. In addition, fluid shifts from the interstitial spaces into the vasculature to increase preload. These responses are effective at maintaining BP in patients with a loss of up to approximately 30% of the total blood volume. NGT's increased heart rate and signs of peripheral vasoconstriction are consistent with these compensatory changes. Her systolic blood pressure is still low, however, and she has signs of decreased perfusion to her brain, manifested by confusion and disorientation. Given the severity of her condition, if intravascular losses are not rapidly replaced, myocardial dysfunction may ensue and lead to irreversible shock. The goals of resuscitation of patients in hypovolemic shock are the correction of inadequate tissue perfusion and oxygenation, and limiting secondary insults. Heart rate (BP) and urine output have been traditional markers for the adequacy of resuscitation, but reliance on these endpoints alone is acceptable only in the initial management of hemorrhagic shock. One concern is that patients may persist in a state of compensated shock even after these parameters are normalized. Ongoing deficiencies in oxygen delivery to vital organs may progress, and if left untreated, organ dysfunction and death may result. Measurement of base, that is, bicarbonate, deficit and lactate levels can be used to assess the global adequacy of perfusion by tracking trends, ensuring that the levels are decreasing. Metabolic acidosis can signal that resuscitation is incomplete despite normal vital signs. The next question reads, is an IV saline solution adequate to compensate for NGT's blood loss? What other fluid options are available to resuscitate this patient? Once an adequate airway is established and initial vital signs are obtained, the most important therapeutic intervention in hypovolemic shock is the infusion of IV fluids. Initially, crystalloids or colloids are used to restore blood volume as blood products are limited, costly, and transfusion of these products carries a risk. Blood products may not be immediately available and are frequently unnecessary to manage mild shock, that is less than 20% blood loss. We will contrast crystalloids versus colloids. Resuscitative crystalloids are isotonic solutions that contain either saline 0.9% sodium chloride, normal saline, or a saline equivalent lactated Ringer's solution. Colloidal solutions contain high molecular weight molecules that are derived from natural products, such as proteins e.g. albumin, carbohydrates e.g. dextrins, or starches, and animal collagen e.g. gelatin, and largely remain in the intravascular space, thereby contributing to colloid oncotic pressure, abbreviated as COP. Healthy semipermeable capillary membranes are relatively impermeable to these large molecules. The choice of a crystalloid versus a colloid solution to restore blood volume in hemorrhagic shock is controversial. The controversy primarily involves the ultimate distribution of these fluids in the extracellular compartment, which, in turn, depends on their composition. Isotonic solutions, e.g. normal saline or lactated Ringer's, freely distribute within the extracellular fluid compartment, which is divided between the interstitial and intravascular spaces at a ratio of 3:1. This distribution is determined by the net forces of colloid oncotic pressure and hydrostatic pressure, both inside and outside the capillary vascular space. Consequently, large volumes of crystalloid fluid are required to expand the intravascular space during resuscitation. In contrast, intact capillary membranes are relatively impermeable to colloids and, therefore, colloids effectively expand the intravascular space with little interstitial loss. Comparatively smaller volumes of colloids than of crystalloids are required for resuscitation, and the duration of action is longer. It is thought that 3 to 4 times as much volume of crystalloid compared to colloid is necessary to provide the same degree of volume expansion. Proponents of crystalloids argue that both intravascular and interstitial fluids are depleted in hypovolemic shock because of the rapid shifts between the extracellular compartments. Volume replacement of both fluid spaces is best accomplished by using crystalloids. In addition, loss of capillary integrity in shock can cause the leak of larger molecules, including colloidal molecules, into the interstitium. This increase in the interstitial oncotic pressure would favor fluid movement out of the vascular space into the tissues, with resultant edema. Crystalloids do not produce allergic or hypersensitivity reactions like many of the colloidal agents. Colloids can also cause coagulopathies, have been associated with an increased incidence of acute kidney injury, and are much more expensive than crystalloids. Proponents of colloids maintain that resuscitation with these solutions more rapidly and effectively restores intravascular volume after acute hemorrhage. For a given infusion volume, colloidal solutions, e.g., albumin, will expand the intravascular space 2 to 4 times more than crystalloids, and the intravascular effects persist longer. Traditionally, it has been contended that the larger volumes of crystalloids necessary to restore the vascular space will further dilute the plasma proteins, resulting in a decreased colloid oncotic pressure and promotion of pulmonary edema. However, clinical studies comparing colloids with crystalloids have failed to show any differences in the development of pulmonary edema. This is likely because of the relatively high alveolar capillary permeability to albumin, causing a decreased transcapillary colloid oncotic pressure gradient. Research suggests that certain subgroups may be at greater risk for the development of pulmonary edema, but considerable variance remains because of differences in physiologic endpoints, criteria for assessing pulmonary edema, and the extent of shock. Numerous meta-analyses have compared resuscitation with crystalloids or colloids in an effort to find a consensus among divergent clinical trial results. Two recent meta-analyses failed to show a mortality benefit for resuscitation with colloids compared to crystalloids in patients with sepsis, trauma, burns, or following surgery. Patients receiving hydroxyethyl starch were at an increased risk of death and acute kidney injury. It is important to recognize that study inclusion criteria, that is heterogeneity, differences in fluid management, and dosages provide several limitations to these meta-analyses. Conversely, a more recent randomized, controlled trial found no difference in 28-day mortality or the need for renal replacement therapy in patients with hypovolemic shock who received crystalloid or colloid-based resuscitation. Any mortality difference between colloids and crystalloids at 90 days remains uncertain as trials have shown conflicting results. A Cochrane database meta-analysis found that volume resuscitation with albumin in hypovolemic critically ill patients did not reduce mortality compared to crystalloids and was possibly associated with an increased risk of death in patients with burns or hypoproteinemia. This meta-analysis was heavily influenced by the SAFE trial, the largest randomized, prospective trial to evaluate albumin versus normal saline solution resuscitation in the critically ill. The primary endpoint of the SAFE trial was 28-day mortality, which showed no difference between albumin and normal saline solution. No statistical differences were identified in any of the predetermined subgroups, e.g. trauma, adult respiratory distress syndrome abbreviated as ARDS, or severe sepsis. A trend toward increased mortality in the trauma patients who received albumin led to a post-hoc follow-up study in patients who had traumatic brain injury. A higher mortality rate was seen in patients with severe traumatic brain injury, Glasgow Coma Scale 3 to 8, who received albumin versus those receiving saline for fluid resuscitation. More certain differences between colloids and crystalloids are availability and cost. Crystalloid solutions are readily available and remain 20 to 100 times cheaper than colloidal solutions, therefore, treatment costs can be significantly different and must be considered when choosing between therapies with similar outcomes. Given the lack of evidence for a significant clinical difference between crystalloids and colloids and the greater expense of using albumin, the guidelines for the use of resuscitation fluids developed by the University Hospital Consortium, a non-profit alliance of U.S. academic medical centers, remain unchanged. Use of either normal saline or lactated Ringer's solution would be appropriate for NGT. Colloidal products are not needed at this time, instead, they should be reserved for persistent hypotension despite an appropriate crystalloid challenge. Given the severity of NGT's hemorrhagic shock, blood transfusion is indicated and should be transfused as soon as available. The next question reads, a large-bore IV catheter is inserted into NGT's arm and stat blood samples are sent for type and cross-match, complete blood count, prothrombin time, partial thromboplastin time, and serum chemistry, blood urea nitrogen, creatinine, sodium-potassium chloride and bicarbonate. Warmed lactated Ringer's solution, at a volume of 2 liters, is infused rapidly, and the GI endoscopy suite is notified. NGT's systolic blood pressure has increased to 94 mm of mercury, but the bleeding has not stopped. A Foley catheter is inserted to measure urine output. Lactated ringers is continued, with 500 to 1000 ml boluses ordered to maintain hemodynamic stability while waiting for fully cross-matched blood. Are the doses of lactated ringers given to NGT appropriate? What clinical and objective parameters should be monitored to determine the success of fluid replacement? Volume requirements. Isotonic crystalloids equilibrate rapidly between the interstitial and the intravascular spaces at a ratio of 3 to 1. For every liter of fluid infused, approximately 750 milliliters will pass into the interstitium, whereas 250 milliliters will remain in the plasma. Based on estimated blood loss, the 3 to 1 rule may be applied as a general guideline. For each 1 milliliter of blood loss, 3 milliliters of crystalloid is infused. Because this determination of blood loss is based solely on clinical assessment and not on quantitative measurements, treatment is best directed by the response to initial therapy rather than the initial classification. Close observation of hemodynamic status with consideration of the patient's age, particular injury, and pre-hospital fluid therapy is essential to avoid inadequate or excessive fluid administration. A safe and effective resuscitative approach for crystalloids in hemorrhagic shock is to give 2 liters of fluid as an initial bolus as rapidly as possible for an adult or 20 milliliters per kilogram for a pediatric patient. Additional fluid boluses may be necessary, depending on the patient's response. Between boluses, fluids are slowed to maintenance rates 150 to 200 milliliters per hour for adults, weight-based up to 100 milliliters per hour for children, with ongoing evaluation of the patient's physiologic response for signs of continued blood loss or inadequate perfusion that would indicate the need for additional volume replacement. The fluid boluses given to NGT are an appropriate initial measure, then assessment of her perfusion is vital to determine the need for additional boluses. Normalization of BP, heart rate, and pulse pressure, that is the difference between systolic blood pressure and diastolic blood pressure, indicate improved circulation. Signs that actual organ perfusion is normalizing and that fluid resuscitation is adequate include improvements in mental status, warmth and color of skin, improved acid-base balance, and increased urinary output. The minimal acceptable urine output is 0.5 ml per kilogram per hour for an adult, 1 ml per kilogram per hour for a child, and 2 ml per kilogram per hour in an infant under 1 year of age. Persistent metabolic acidosis in normothermic shock usually indicates the need for additional fluid resuscitation. Sodium bicarbonate administration is controversial but is not recommended unless the pH is less than 7.2. Monitoring serum lactate and base deficit is important to determine adequate resuscitation. As perfusion improves, lactate and base deficit will decrease, thus, the actual values are not as important as the trend. It is important to note that resuscitation is not defined by just one value or number, such as BP, but by the constellation of indicators of overall perfusion. The next question reads, is there an advantage to using lactated ringers solution versus normal saline solution? The choice of replacement fluid varies widely in clinical practice. Normal saline solution has a supraphysiologic chloride content, while lactated ringers contains a more balanced chemical composition. Large volumes of normal saline can cause hypochloremic metabolic acidosis, thereby worsening the tissue acidosis from hypovolemic shock. This may also cause immune and renal dysfunction, but survival differences have not been seen and the clinical significance is unknown. Lactated ringers, in contrast, is a buffered solution designed to simulate the intravascular plasma electrolyte concentration. It contains 28 milliequivalents per liter of lactate, which is metabolized to bicarbonate in patients with normal circulation and liver function. In situations in which hepatic perfusion is reduced, that is 20% of normal, or hepatocellular damage is present, lactate clearance may be significantly decreased, particularly in combination with hypoxia, that is an SaO2 of 50% of normal. In patients with shock and those having cardiopulmonary bypass during surgery, the half-life of lactate, normally 20 minutes, increases to 4 to 6 hours and 8 hours, respectively. Because unmetabolized lactate can be converted to lactic acid, prolonged infusion of lactated ringers could cause tissue acidosis in predisposed patients. Concern about the high sodium and chloride content in normal saline has led to the first-line selection of more balanced resuscitative solutions, e.g., lactated ringers, in patients at high risk of acidosis, including those with trauma, burns, diabetic ketoacidosis, or undergoing surgery. Lactated ringers, however, should be avoided in patients with metabolic alkalosis, lactic acidosis, or hyperkalemia. In practice, normal saline and lactated ringers solutions typically are used interchangeably because neither solution appears to be superior to the other. The next question reads, what is the role of hypertonic saline solution in the setting of hemorrhagic shock? The advantage of hypertonic saline, that is 3% to 7.5% sodium chloride solution as a resuscitative fluid, is the smaller volume of fluid required to expand the intravascular compartment compared with isotonic solutions. This could be a particular advantage in the pre-hospital setting, e.g., field rescue by emergency medical technicians, given the large volumes of fluids necessary to restore ongoing blood loss. With a high concentration of sodium, hypertonic saline solution exerts an osmotic effect, translocating fluid from the interstitial and intracellular compartments to the intravascular space. Consequently, plasma volume is rapidly expanded to a greater extent than similar volumes of crystalloid solutions, and systemic BP, cardiac output, and oxygen delivery are readily increased. Hypertonic saline solution also improves myocardial contractility, causes peripheral vasodilation, and redistributes blood flow preferentially to the splanchnic and renal circulations. In addition, intracranial pressure is reduced, but to date hypertonic saline has not been shown to improve outcomes in trauma patients with concomitant head injury. Other recent studies have shown that hypertonic saline may have beneficial effects on circulation, inflammation, and endothelial function, which may be beneficial in patients with septic shock and acute lung injury. More robust clinical trials are needed to determine if these preliminary findings translate into improved clinical outcomes. It is difficult to make conclusions about the utility of hypertonic saline for fluid resuscitation because of the heterogeneity of studies and solutions. The majority of data regarding the use of hypertonic saline in hypovolemic shock come from the trauma population. No high-quality trials are available in patients with GI bleeding. Hypertonic saline effectively raises BP in patients with hypovolemic shock, but as with isotonic saline the effects are transient and it has not been shown to improve mortality. These clinical trials suggest that hypertonic saline solution may be safe and effective for the initial resuscitation of hemorrhagic shock. Despite these positive findings, hypertonic saline solutions are not widely used. This is possibly because of its safety profile as a high-risk medication. Hypertonic saline is prone to dosing and administration errors, particularly when used by clinicians who are unfamiliar with the product. The osmolarity of hypertonic saline can range from 1026 to 2567 milliosms per liter for 3% to 7.5% sodium chloride, so infusion through a central line is preferred to minimize phlebitis. Hypertonic saline may cause hyponatremia and hypochloremic metabolic acidosis, resulting in rapid fluid shifts between cellular compartments and potentially devastating effects such as osmotic demyelination syndrome. However, most studies have not reported such events, which may be because of a lack of power or the relatively small volumes of hypertonic saline used for resuscitation. The next question reads, NGT has received 4 liters of lactated Ringer's solution to maintain hemodynamic stability. Her current vital signs are BP 98 systolic 54 diastolic, a heart rate of 108 beats per minute, and a respiratory rate of 30 breaths per minute. She is still confused and is becoming more agitated and combative. Urine output has been only 30 milliliters in the past 30 minutes. Laboratory results include the following. A hematocrit of 21%. It is down from 26%. A hemoglobin of 7.1 grams per deciliter. It is down from 8.9 grams per deciliter. A pH of 7.14. A PCO2 of 34 mm of mercury. A PO2 of 106 mm of mercury. Bicarbonate of 16 milliequivalents per liter. 2 units of packed red blood cells are now available, and NGT is being prepared for the GI endoscopy suite. Describe the current status of NGT's resuscitation and the need for blood products. NGT is still exhibiting signs of inadequate tissue perfusion. Although her BP has improved and her heart rate has decreased, her mental status has declined, she is oliguric, and her ABG indicates metabolic acidosis. NGT has not been adequately resuscitated from her hemorrhage, is still actively bleeding, and should receive available blood at this point. The prior conventional approach to the transfusion of critically ill patients was to maintain the hemoglobin greater than 10 grams per deciliter or the hematocrit greater than 30%. It has been argued that these liberal transfusion goals are justified in acutely ill patients, particularly those with cardiovascular disease, because the compensatory mechanisms to maintain tissue oxygen delivery are impaired. However, randomized, controlled trials have shown that a restrictive transfusion strategy, with a target hemoglobin 7 to 8 grams per deciliter or transfused if symptomatic, is associated with equivalent or better outcomes in hemodynamically stable critical care, surgical, and medical patients. In acute hemorrhage, the actual degree of blood loss is not accurately reflected by the hemoglobin and hematocrit values, and it also does not take into account the body's ability to compensate for the loss of oxygen carrying capacity. Because it takes at least 24 hours for all fluid compartments to come to equilibrium, a normal hematocrit or hemoglobin concentration in the setting of hemorrhagic shock does not rule out significant blood loss or indicate adequacy of transfusion. Only when equilibrium has been reached can these measures be used reliably to gauge blood loss. On the other hand, if cardiopulmonary function is normal and volume status is maintained, an increase in cardiac output can compensate for a reduction in hemoglobin, that is oxygen content, to a certain degree. Because inadequacy of tissue perfusion, and hence oxygen delivery, is the primary abnormality in shock, the need for transfusion therapy is more accurately determined by the patient's symptoms and oxygen demand, rather than an arbitrary hematocrit or hemoglobin value. Calculation of oxygen delivery and oxygen can be used to determine the adequacy of perfusion. Although these values can be determined by use of a PA catheter and arterial and venous blood samples, for practical purposes the patient's response to initial fluid resuscitation and clinical signs of inadequate tissue perfusion are the primary determinants for blood transfusion. Patients who are not acutely bleeding and who do not respond to initial volume resuscitation or who transiently respond but remain tachycardic, tachypneic, and oliguric clearly are underperfused and will likely require blood transfusion. Patients who have acute bleeding or who demonstrate signs of underperfusion should be considered for transfusion much sooner, thus, NGT should receive a transfusion. So there you have it, our highly esteemed viewers and listeners, that brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 318.